Okay, so we'll go ahead and get started. This would be module 5. We're going to talk about trauma and stress and the disorders related to these phenomena. So we'll just go ahead and get started right here. Again, if you have any questions about any of the assignments or anything else, please shoot me an email. I am more than happy to help you out. Okay, so first of all, let's talk about stress. We need to talk about stress if we're going to talk about trauma. So, as we know, stress is a part of life that we're all going to experience. And here's the thing, it's not always bad. It is not always bad. Stress is an adaptive phenomena that we all experience as it is motivational. It's our natural response to anything that might be hard or challenging. It could even be triggered by things that are positive. So things like, yes, like a puzzle, or even something like if you're an athlete, maybe there's a big game coming up. You might get stressed out, or you might be specifically stressed right before. But what that can do is enhance your adrenaline and motivation to perform at a higher level. Or stress can also be triggered by negative things, something like financial difficulty, or housing insecurity, or food insecurity, or when your car breaks down. Stress can be experienced. So, what happens when you're stressed is your body, especially at high levels of stress, your body's going to go into fight or flight. And what happens here is basically your central nervous system is responding to keep your body and mind alert. So, what happens when this occurs is it's similar to, it might not be as intense as, but it's similar to as if you're being chased by a bear. But again, probably a little bit lower level. You aren't necessarily going to run, but your heart rate's going to increase, your blood pressure is going to rise, your pupils might dilate, your muscles might tense. But if you can manage your stress in healthy ways, you can perform better. So we also have to talk about life stressors. These are going to be events or experiences that are going to cause stress. Um, Again, some stresses, we all have to deal with these. Everybody's going to deal with stress. They can be small and easy to manage. And again, this is relative. Depending upon who you are, you might interpret the situation as a life stressor that's easy to deal with, whereas somebody might not be able to, and it's much harder. But common small stressors might be like a busy day at work or school, or a disagreement with a partner or a parent or a roommate. Other stressors might be a little bit more difficult, something like losing a loved one, separation or divorce, or if you were to become seriously ill or somebody else close to you becomes seriously ill. Okay, so now that we know a little bit about stressors, there are stress related disorders that can be diagnosed. And these disorders are called adjustment disorders. And even though it's called adjustment disorders, plural, it's really just one disorder. So, with that being said, I'm trying to go to the correct page as well to give you all of the insight. So hold on with me for a second. So, in order to be diagnosed with adjustment disorders, there has to be some sort of specific stressor that has occurred within the last 3 months since symptoms have arisen, or the onset of the stressor. So maybe, okay, let's say maybe you lost your job and you really enjoyed that job, and maybe it is causing some financial difficulties or just a variety of stress in your life. And let's say that happened about 2 months ago, and since that time you're okay for a little bit, but then you've started to develop these symptoms that we're going to talk about below here, that were the result or associated with this specific stressor. That's what's important about this disorder. You have to be able to identify the stressor that is causing the symptoms. Otherwise, we might be looking at another disorder. And so you have to have one or both of the following, according to B. You have to have marked distress that's out of proportion to the severity or intensity of the stressor. specifically considering the context and cultural factors that might influence the symptom severity and presentation. And so what that means is the distress that you're experiencing is out of proportion. It is much higher than it would be otherwise. So maybe you are starting to not be able to function as a result of the stress. Maybe you're having emotional outbursts. Maybe you might, let's see here. Maybe you might be experiencing little bouts of depression, but they're not clinical in nature, or anxiety that's not clinical in nature, but you're experiencing some sort of negative affect, emotion, behavior that's associated specifically with this stress that you've experienced. And as a result of that, it's getting in the way of you functioning, or going to school, or your new job, or taking care of your family. So you have distress that is out of proportion compared to what most people would experience, and it's getting in the way of you functioning. That is indicative. Okay, that is going to indicate that you could be diagnosed with this. And you have to make sure that the stress related disturbance, your distress, it doesn't meet the criteria for another disorder. So you have to make sure it's not an anxiety disorder, depression, prolonged grief disorder, possibly. You do have to consider that. That's why the 3 months in the distress are important here. Um, and once the stressor is ended, the symptoms do not persist for more than 6 months. Once it prolongs for more than 6 months, they're probably going to bump you up to another disorder if you're still experiencing this distress. But the hope is that if you do get diagnosed with this disorder, you do possibly get recommended for like cognitive behavioral therapy, or some other sort of treatment, or community resources that help you process the stress that you're going through. Because again, this will only be an active diagnosis for approximately, I mean, basically up to 6 months. So with that being said, I think I might have a few other examples. So in regard to this, and I know it's not in the PowerPoint, but I'm just going to mention this before we talk about trauma. When it comes to adjustment disorders, there's probably a lot of people that have adjustment disorders, especially after a major stressor in life, but they never get diagnosed. Those who are in outpatient mental health treatment in the United States, with a diagnosis of adjustment disorder, it ranges from about 5 to 20%. And those are just people who are attending therapy. So you can see that it's a fairly common disorder that is diagnosed. And I have no doubt that there's even more people who are going to never be diagnosed. Okay, so with that being said, okay, we talked about stress. Stress is going to be different than trauma. And I just want to make this comment that the way that the DSM portrays trauma is different than the way that most people experience it in real life. There has to be a specific type of trauma experience to be diagnosed with PTSD or other trauma-related disorders. So it's very narrow. However, I want to make the point that nobody's trauma is insignificant. I don't want anybody's trauma to feel like it is minimized. All trauma is impactful in people's lives. And so I just have to make that note personally and professionally. But unfortunately, the APA and DSM only encapsulate trauma in a specific way here. So when we talk about trauma, this is going to be a disturbing experience that results in fear, helplessness, disassociation, confusion, or some other disruptive feeling that's intense enough to have a long-lasting negative effect on how somebody functions. And so, and again, this is relative. Something that's traumatic for somebody might not be traumatic for somebody else. But nonetheless, there's something that happens that is incredibly disturbing that results in these characteristics. And it could be anything. And We do consider any event that disturbed your mental or emotional balance in a significant way as trauma. And these are very severe examples. So witnessing violence, being a victim of violence, if you've ever been physically, sexually, or emotionally abused, if you've been part of a major accident, if you've been bullied, if you've been forced to leave your home, a lot of these things are traumatic. And within our lifetime, about 60% of men and 50% of women will experience at least one trauma in their life. Now, here's the thing is that most of us, we're going to be able to cope with it, process it, and return to a semblance of normalcy. It's when these things don't happen that we head toward psychopathology. Okay, here's some other examples of trauma. And again, these are pretty extreme, but with these, we are in the realm of definitely qualifying for a disorder like PTSD. So something like military combat. I think that's what most people think of when they think of PTSD and trauma. And we do know PTSD was first diagnosed in soldiers. I think it was after World War I, and it was known as shell shock or neuroses. Serious motor vehicle accidents, plane crashes, boating accidents, industrial accidents, natural disasters, tornadoes, hurricanes, volcanic eruptions, robberies, muggings, shootings, rape, incest, child abuse, hostage taking, kidnappings, political torture, imprisonment in a concentration camp, and refugee status. If you do not, if you are basically no longer considered a citizen in your own country and forced to leave in some way, that is incredibly traumatic. I do not think we think about that often enough. But in the United States, trauma related to the highest rates of PTSD are those who are survivors of rape, military combat and captivity, and ethnically or politically motivated internment and genocide. So all very, very, very severe types of trauma. Okay, so before we talk about PTSD, we do have to talk about acute stress disorder. Now, acute stress disorder is something that could possibly precede PTSD or just be diagnosed on its own. So with acute stress disorder, you have to be exposed to actual or threatened death, serious injury, or sexual violence in at least one of the following ways. Now, as you can see here, it's a narrow definition of trauma. So at least one of the following ways: you directly experienced the traumatic event. So you experienced somebody, your life was threatened, you incurred a serious injury, or you incurred sexual violence. You witnessed somebody else be a victim to one of these things. You watched somebody else die or be killed or have their life threatened. You watch somebody else obtain a serious injury, or you would watch somebody else incur sexual violence. You learn that the traumatic events occurred to a close family member or close friend. Again, any of those. Kind of getting specific to hopefully offer a little bit of perspective here. We could even talk about COVID resulted in an immense amount of PTSD, especially among healthcare workers, first responders. If we go back long enough, here's an example of close family member, close friend. If you had a family member, a close friend on 9/11, and I know some of you were not born at that point, but that you got the call that they were in one of the buildings on 9/11 and went down, that would qualify as this. And I can even go back and say, like with number one, directly experiencing the traumatic event. Maybe you were in the buildings, witnessing in person the event as it occurred to others. You were standing outside the buildings watching. And again, learning the traumatic event occurred to a close family member, a close friend. You got the call that you had a family member in the building. Then number four is kind of interesting in that it includes experiencing repeated or extreme exposure to aversive details of the traumatic event. So this is really there for first responders and police officers, because even if, maybe they weren't down at ground zero. Maybe they didn't directly witness it, but maybe they were one of the first responders in regard to the dig or the cleanup, and they were consistently exposed to ground zero, or they were investigating, or they were collecting body parts. And here's the thing, it does not apply to exposure through electronic media, television, movies, or pictures unless it is work related. So for any of us, and I know most of you are too young for this, but any of us that watch those towers fall over and over and over, that does not qualify as a PTSD diagnosis, even though it, for some people, it did cause trauma, unless the exposure is work related. So if there was an investigator that was looking at those, at the planes fly into the buildings and those buildings fall over and over and over again on a computer or some sort of media, that would qualify because that is part of their job. So that's going to be acute stress disorder. If you've been exposed to at least one of those, then on top of it, you have at least 9 of the symptoms. Okay, so you have to have been exposed to one of those things we just talked about. Then you have to have at least 9 of the following symptoms, and you can mix and match. So you either have to have intrusion, dissociative symptoms, negative mood, avoidance symptoms, or arousal symptoms. And again, the ones under these are the ones that you can mix and match, and you need 9 of. So recurrent, involuntary, and intrusive distressing memories of the event. So again, you're just thinking about it over and over and over, and you're not trying to think about it. It's just flashing before your eyes. Dreams. It is stuck in your dreams. Dissociative reactions in which an individual feels or acts as if the event were recurring. These are like flashbacks. Intense or prolonged psychological distress or physiological reactions in response to internal or external cues that symbolize or resemble an aspect of the event. So again, talking about 9/11, 9/11 comes around. That individual is incredibly distressed. Maybe they are nauseous as a result of that day coming around. Internally, maybe there is a certain feeling that represents that day, and when that feeling comes along, that results in vast psychological distress. So again, those intrusive symptoms, things that they're not asking for, they're just happening to them. Dissociative symptoms, we'll talk further about dissociation as we go, but it's basically as if you are removed from reality. You're removed from your body or from the world psychologically. An altered sense of the reality of one's surroundings or oneself, or the inability to remember an important aspect of the event. So kind of that blank space. If you've been through something that is traumatic, sometimes you just don't remember the entire event. Your brain might try to fill it in, but there's also possibly these blank spaces that your brain doesn't fill in, and that is trauma. Your brain's trying to protect itself from the traumatic event and really is almost not wanting you to remember it. And yes, an altered sense of the reality of one's surrounding yourself, feeling as if your body does not belong to yourself or you do not belong to this world. Negative mood. Oh, I'm sorry about that. Negative mood, the persistent inability to experience positive emotions. And so maybe this is depression, maybe this is grumpiness, maybe this is just like a flat affect, like you just can't feel happiness. Okay, so again, we're looking for 9. We're looking for 9. Avoidance symptoms. These are going to be efforts to avoid distressing memories, thoughts, or feelings about or closely associated with the event. So this is when somebody is actively trying to not remember or trying to avoid feelings associated with whatever happened. Avoiding external reminders that arouse the memories, thoughts, or feelings about it. Again, avoiding any sort of like 9/11 documentary. Avoiding New York City. Avoiding anything that had to do with that day that could cause one to remember things. Again, so somebody's actively avoiding portions of the world, whether that is portions of one's thoughts or the world around them. And then there's arousal symptoms. These are pretty common, especially with trauma, pretty severe traumas, having difficulty sleeping, being irritable, or having angry outbursts that can kind of come across as like verbal or physical aggression toward people or objects. It doesn't really matter, but it's those outbursts that come out of nowhere. Hypervigilance. This is when they're on guard all the time. They're always on guard. They're always looking. It might even come across as a little bit of paranoia, and that maybe they're looking out the window a lot, searching for something that's not there. Having a hard time concentrating, focusing. and having an exaggerated startle response. So if somebody were to come up behind them and tap their shoulder just to say hi, they might, they will be startled and potentially swing around at the person. So they're jumpy. Again, all of that has to do with an overactive central nervous system. That is all really associated with that fight or flight response. That is pretty much active all the time with individuals that experience that. So you need, again, between these 2 pages here, you need 9 of these. Okay, so when it comes to the duration, they have to, okay, once the trauma has experienced has happened, the disturbance is 3 days to 1 month after the trauma. Again, that's a very, very short window of time. A lot of people aren't going to be diagnosed with this because a lot of people won't really get help until a long time afterwards. But for some people, once they experience the trauma, maybe they are in, a medical clinic or a hospital or something like that, and there is a therapist, there is a psychiatrist. They could be diagnosed with this if it's at least 3 days, but not more than 1 month after the trauma. Once we hit the end of that range, you probably get rolled into something else, or hopefully the symptoms have died down. Because again, when you experience any sort of trauma, you might experience these things. And the hope is that they just don't last. And here's the thing, it's causing significant distress. Okay, so it's outside of anything that you can handle emotionally, psychologically, physically, or it's getting in the way of your life. Now, here's the thing, is that 50% of individuals who eventually develop PTSD initially present with acute stress disorder. The rest of them just showed up too long after the initial trauma to be diagnosed with this. So they showed up after a month of the trauma, beyond 1 month after the trauma, so they could not be diagnosed with this. But again, what happens once this diagnosis is made, once we hit that 1 month mark, you're going to get rolled over into another diagnosis if you're still experiencing those symptoms. If not, your diagnosis drops off. But as you can see here, 50% of people who are later diagnosed with PTSD start with this disorder. Okay, so when it comes to PTSD, because this is always the big one, but again, take note that there's other diagnoses other than PTSD. And I just want to see here if there's anything. I could get some additional numbers for you. Okay, I think we covered everything. So PTSD. The main feature of PTSD is developing characteristic symptoms following exposure to, again, trauma, or experiencing trauma as a result of an event. People with PTSD and the way they express themselves or portray themselves, it's going to be different. Everybody with PTSD is going to have symptoms. Again, like with acute stress disorder, you're going to be able to mix and match your symptoms. So somebody with PTSD might exhibit these symptoms, somebody else might exhibit other symptoms. So for some, it might be fear-based re-experiencing. Emotional, behavioral symptoms might be the main symptoms, but for others, it might be anhedonia. Okay, we have not talked about anhedonia yet, but I will go ahead and tell you because it is in a lot of disorders, including mood disorders as well. But this is when you don't have the ability to feel pleasure or feel good or feel happiness. It's just gone. That's anhedonia. Or dysphoric mood states and negative cognitions may be prominent, so negative thoughts. In others, maybe it's an arousal or reactive externalizing symptoms. But in others, they're disassociating. So you could get a whole range of symptoms when we're talking about PTSD. And again, it might be, again, a mix and match of all of those things. So, oh, wrong way, my bad, guys. Okay, so again, when it comes to PTSD, we can only diagnose people who are over the age of 6. Okay, that is important. But that also indicates we can diagnose kids who are very, very young. In a lot of these diagnoses, we are looking at diagnosing people usually like over the age of 18, but PTSD, it goes all the way down to 6. So again, you're going to see right here that letter A is exactly the same as acute stress disorder. exactly the same. And as a result of that, I'm not going to read through it, but you have to be exposed to at least these things in at least one of the following ways. That is absolutely uh, required. Absolutely required. Okay. So you have that, you've experienced the trauma. Then again, what you're going to see here, instead of being able to completely mix and match symptoms in every single category, you have to have specific amounts of symptoms in every category now. So instead of mixing and matching completely and freely like an acute stress disorder, now we need so many symptoms in each category. So it's a little bit more specific. Okay. So when it comes to this, all right, and with B, you have to have at least one of the following. And for the most part, these are going to be pretty similar. The distressing memories or involuntary memories of the event. Again, this is the intrusive symptoms. Recurring distressing dreams, the flashbacks, psychological distress, whenever there's anything, any sort of cues that symbolize the event, or physiological reactions to cues that symbolize the event. So again, those intrusive symptoms are still there. You need one of them. Then we have C. You avoid stimuli. You avoid anything associated with the event. Again, these are the avoidance symptoms. And this begins after the event occurred, as evidenced by one or both of the following. So you got to have at least one of these. You either try to avoid the internal aspects of it, so like the thoughts or feelings associated with the event, or you avoid the external things, like places, people, things associated with the event. We also have D. These are going to be the negative alteration in your thought patterns and mood associated with the event. And again, they either have to begin or get worse after the event occurred. So we can't have any of this. You can have some of these things prior to, but they have to get worse or they have to completely appear on their own. So that's of interest here. But you have to have at least two of the following. The inability to remember an important aspect of the event. Again, those black spots or blind spots. Persistent and exaggerated negative beliefs or expectations about oneself, others, or the world. So that one's a different one. That's an additional one that's in there. And with this, again, it's like negative beliefs or expectations about yourself, possibly, in that I am worthless, I am helpless, I am a horrible person. Or you might think that about others, or even the world. The world is a horrible, awful place. And so it's exaggerated, not only negative, but exaggerated outside the realm of what some people think on a daily basis. Sometimes we just have a bad day. This is an exaggerated bad day all the time. Persistent, distorted thoughts about the cause or consequence of the event that leads the individual to blame themselves or others. So this could kind of be like survivor's guilt if they blame themselves. Or also possibly others. These persistent thoughts, again, they're distorted, so they're not necessarily true, but putting the responsibility of whatever happened on somebody else that maybe wasn't responsible. Again, maybe somebody was responsible, but those would be correct cognitions. These are ones that are distorted, that are not real. A persistent negative emotional state, again, like we were talking about, guilt, shame, depression, horror, fear, feelings of detachment or estrangement from others, not feeling like one fits in. You do see this, especially with like individuals who are coming back from combat. They may not feel like they fit in with their family or friends at home anymore. There is an adjustment period, but also possibly because of what they've experienced. And nobody else is going to understand it. Also, diminished interest or participation in significant activities. So things that were once pleasurable are no longer pleasurable. If somebody has a family, again, the military example, again, they get back and they used to enjoy going to the movies with their family. They don't do it anymore, or getting together with family. They don't do it anymore. They don't participate in things that they used to do, whether it's with friends, family, other things. Maybe they did solo, maybe they went to the gym or took part in a civil group, and they don't do that anymore. The inability to experience positive emotion. So there's the anhedonia again, and you need two of these. All right, we also have E. This is going to be your arousal symptoms. So arousal and reactivity. Again, associated with the event, not anything else, beginning or worsening after the event occurred, and you have to have at least two of them. So being irritable or having these angry or rageful outbursts that can be verbal or physical in nature. And again, here's a couple more that are, this is one that's not included in acute stress, reckless or self-destructive behavior. So maybe somebody, again, maybe got back from combat and, maybe they had a beer here and there and they get back and they start drinking excessively, like way outside of what was normal, even when they were overseas. They get back and they start drinking excessively, or maybe they drive in a reckless fashion, or maybe they're trying to ruin a relationship they're in, and they might not even be aware of this. Probably not. It's kind of unconscious, but they're doing self-destructive things that they wouldn't otherwise do. The hypervigilance, exaggerated startle response, concentration issues, and difficulty with sleep. And again, you need at least two of those. And here's the thing, is the duration of the disturbance is at least a month. Now, if you remember from the acute stress disorder, you have, after the trauma, 3 days to 1 month. Once you hit that month, acute stress disorder, if you've gotten treated, acute stress disorder drops out. You're reevaluated to determine what symptoms you have. And again, if you have symptoms and they're continuing, you are going to probably fit the diagnosis for PTSD. And so they will roll you from that acute stress disorder diagnosis right over to post-traumatic stress disorder. And so that's why it says the duration of the disturbance is at least 1 month. You have basically documentation, or again, self-report, report by family. You've experienced this for 1 month, making you eligible for a PTSD diagnosis. And of course, if you're experiencing these after a traumatic event, you are probably going to be experiencing distress and a hard time functioning. And all of this behavior is deviant. We talked about those 3Ds. All of this behavior is deviant. We do not expect people to experience whether these emotions or psychological or cognitive phenomena or the behaviors. We do not expect that from people or in combination with one another. We do not expect that. That is outside of the norm. Thus, you have the deviance, you have the distress, and you have the dysfunction. Okay. Okay. Now, in general, symptoms of PTSD are going to usually start about 3 months after the traumatic event. So there's no timeline. That's the thing, is there's no timeline. You don't have to experience PTSD 3 days after, get diagnosed with acute stress disorder, and then roll over into PTSD. That's just, yep, it happens here and there, but not always. Most commonly, it'll begin about 3 months after the traumatic event, but it might be months or years. So somebody maybe who served in Vietnam, they came back, they were okay, everything was fine. 20 years later, they started to experience PTSD symptoms. That is a delayed expression, but it's totally, it's possible. It's absolutely possible. People talk about this in regard to sexual assault, and that might occur, and the victim might seem to be functional after it, but you go 10 years down the road and they start to experience these trauma-related symptoms. That is the brain was able to function for a certain amount of time until that trauma resurfaces and they experience these symptoms. So when people say, why didn't they experience this sooner or things like that, the brain doesn't work on a time schedule. The experience of psychological symptoms aren't clear cut. They're not black and white. Symptoms that can occur at any point in time based upon an environmental stressor or another type of stressor or genetic expression. It's not on a timetable, and it's unfortunate that people assume they understand how psychological symptoms manifest themselves, because even the smartest people in the room don't completely understand it, but we do know it can appear at any point in time. Now, the duration of those symptoms varies. About half of people that are diagnosed with PTSD do recover within 3 months. Those are probably people that are going to, they'll have some sort of treatment. They'll have some, there will be some sort of treatment that they obtain. And with treatment, PTSD symptoms can lessen or dissipate to a level in which PTSD is no longer diagnosable. Some people are going to remain symptomatic for more than 1 year and sometimes more than 50 years. So again, depending upon the type of treatment somebody seeks, whether they seek any treatment, and sometimes even if they do, when they're in treatment, it doesn't work and they experience these symptoms for the rest of their life. Okay. So the prevalence rates. Okay, these are going to vary just a hair. Let me see here. These are about the same. Okay, so when we talk about the lifetime prevalence, what the lifetime prevalence, okay, this is the national lifetime prevalence. So if you're in the United States, the chances of you developing PTSD in your entire life, across your entire lifespan, is about 6 to 8%, which is a lot. That's a very, very high rate. A very high rate. The lifetime prevalence for women, 8 to 11%. So as many as 1 out of 10 women in the United States at some point in time will experience PTSD. Men, 4 to 5%. Now, the chances of you developing PTSD in the next 12 months is right around 4.7, just rounded up to 5%. So 1 out of 20 people, you have a 1 out of 20 chance of developing PTSD in the next 12 months. Now, when it comes to a study that was conducted amongst 24 countries, so this is the World Mental Health Survey National Lifetime DSM-4 prevalence, and this is a little bit older, but it's still applicable to a certain degree. It will be much more helpful once we get all of the data from the COVID era. I apologize, from the COVID era. I would expect that within the next couple of years to be reflected in these numbers, and it's going to be much higher. But the world national lifetime prevalence of PTSD is right around 4%. And there's probably differences in here. You can look at, we're talking about 24 countries. Are they all high income countries? I'm not exactly sure. Are there low income countries in there in which people do not have access to psychiatric care, therapy, counselors? Are these countries that perceive PTSD the same way that we do? Or are there other factors that enhance the chance of somebody developing PTSD or incurring trauma in the United States? I don't have all the answers for that. Now, again, lifetime prevalence for women in the United States, 8 to 11%, which is fascinating. If you go into a conflict-affected area, the PTSD rate is similar to that of women in the United States, right around 11%. So this could be somewhere like Ukraine, Gaza, Syria, Israel, Palestine. And those are just the few that I can think of off the top of my head. I know there's plenty, but that just gives you something to think about. I will leave that up to your interpretation. Okay, so let me see if there's anything else. I went over prevalence rates. One thing that I did not mention, and I will be talking about this with any sort of disorder that heightens this chance, and it does with acute stress disorder too, but with PTSD, there is an increased risk of suicidality. It does, suicide attempt and risk is associated with PTSD. The presence of PTSD has been associated with increased likelihood of transitioning from suicidal thoughts to a plan or attempt. And this is outside of the presence of like a mood disorder or anything else. There's also a connection between PTSD amongst teenagers and suicidal thoughts or behavior, even adjusting for any sort of mood disorder that might be prevalent. So looking at specifically that PTSD. Okay, so let's talk about prolonged grief disorder. This is the major addition to the DSM-5 text revision, as we kind of discussed. And I am of the opinion, again, so the DSM-5 text revision was released in 2022. I do think that this was in direct response to COVID, because there was an immense amount of grief and distress. We probably all knew somebody who got it. Maybe we got it. We might have known somebody who lost somebody. We might have known somebody who died. So I do think that this is a response to that. Prior to this, we did not have a diagnosis for grief. People just, the closest thing we would have is like major depressive disorder, but depression and grief are two different concepts. They're different concepts. And so this is a long time coming. Okay. So with prolonged grief disorder, you have had to experience a death that was at least a year ago. Okay. Of a person who was close to you, or for kids at least 6 months ago, because kids can be diagnosed with this too. But for kids, they could process things even a little bit faster and better than we can. So with them, if it's been more than 6 months and they're still struggling, they may be able to be diagnosed with this. With adults over at least 18, yes, I believe it's 18, it's 12 months. So if somebody has been gone for 12 months and you're still experiencing these symptoms, you might qualify for a diagnosis, because 12 months is a pretty standard period of time to start to process and return to life, even though I have a variety of perspectives of grief. I don't think grief is something that doesn't necessarily disappear. I don't think people get over losses that are significant. I don't necessarily believe that. I'm more so the belief that grief doesn't necessarily even get lighter, but people learn how to carry it better, if that makes sense. You learn how to potentially manage the grief. You learn how to get up in the morning and keep going, but that doesn't mean the grief gets less heavy. You just learn how to carry it better. And again, but for some people that grief does lift. I just don't want people thinking like, yeah, the grief should go away. I don't think so. I just don't. Nonetheless, okay, since the death at least 12 months ago, a person has developed a persistent grief response characterized by at least one or both of the following, which have been, please ignore my spelling, I am recognizing this as we're going, been present most days to a significant degree. So they're experiencing this consistently. That's also something with grief that, again, working in the field and experiencing this, again, when life happens, you just know, I know you guys know these things, but when you're experiencing grief, like some days might kind of feel okay, but then other days it's just like a wave crashes over you. And so you are kind of out in the ocean in your little floaty, and there's some days where the waves aren't that bad and you're just kind of floating along and it's okay. But there's other days where it's just a storm and every wave is crashing on you. That's how I kind of perceive grief. And so, quote unquote, normally there's good and bad days. When it comes to somebody experiencing this disorder, there aren't good days. There are almost never good days. Most days to a significant degree, and the symptom has occurred, again, nearly every day for at least the last month. So again, they're not having clear days on the ocean. Now, there's an intense yearning or longing for the deceased person. Again, they need that person. They want to have that person back. And again, that is common with grief. You want that person back, but this is getting in the way of their functioning. They're feeling this so much that it is causing them immense, like physical or psychological pain. Or they're preoccupied with thoughts or memories of the deceased person. Let's see here. And with the yearning and longing, it can often be, if you're looking for like physical types of identifications, intense sorrow, frequent crying. Let's see here. Those are indicators as well. Yeah, preoccupation with thoughts or memories of the deceased person. They can't think of anything else. That's all that is encompassed in their mind. Again, we're talking about 12 months after, sorry, trying to get going, after the death. Then, okay, so those are in place. Then you have to have at least 3 of the following symptoms. And they've been present most days to a clinically significant degree. So it's outside what is considered to be normal in this culture. That's what's tough about this. It's culturally bound. What is expected within this culture. And the symptoms have occurred nearly every day for at least the last month. Again, 12 months since the death, but we're looking at like this, the last month of symptoms. So identity disruption since the death. So again, feeling like part of you has died. And again, these are very common right after death. But again, as time goes on, you learn to carry this a little bit better and continue to function. So again, identity disruption. Part of you is gone. You're in denial about the death. You do not believe that it happened. That is something that happens as we start to process death, as we realize like, no, this is happened. This is real. Somebody with this has not possibly recognized that this is real. Avoidance of reminders the person is dead. So, maybe avoiding, their house and the fact that it's empty, or any sort of anything, like there's a will that has to be taken care of. Avoiding that's an indication the person is dead. Anything related to anybody offering condolences or bringing food over, avoiding all of that. Intense emotional pain related to the death. Difficulty reintegrating into one's relationships, activities after death. Again, they don't have the ability, again, to restart parts of their life. That hasn't happened yet. Emotional numbness as a result of the death. So again, we have intense emotional pain, and then we have emotional numbness, and that there's just no emotional response to anything. Either you get lots of response or no response. Feeling that life is meaningless as a result of the death. There's no reason for life to go on. There's no reason for me to be here. And intense loneliness as a result of death. I'm alone. I don't know what I'm going to do by myself. And these are things that they might say, but I'm just hopefully giving you an idea of what this might feel like or look like. And with all of these, we've probably either seen these within ourselves or in others after we've experienced a death. Again, the difference is that as time goes on, these do diminish to a certain degree. Okay, because here's the thing, it causes, we're talking a year out from the death, it causes clinically significant distress, or again, which is present in those symptoms, or they're not functioning in society. So, and that might be like an indicator for even a family member to be like, okay, it's been a year, and they still haven't restarted work, or they haven't started going back to the gym, or they haven't went out to the weekly family meal, or there's something that hasn't gone back to, or they haven't started to go back to doing some of the things they used to. And the duration and severity of the bereavement clearly exceeds expected social, cultural, or religious norms for the individual's culture and context. So here's the thing, is that in some cultures, a year of grieving, that might That might not be enough. I mean, maybe you got to go out 2 years, depending upon how long it's expected of you to grieve. I mean, I will be completely honest with kind of the subculture I grew up in. It's, Nebraska Sandhills, rural, pull yourself up by your bootstraps kind of culture. A year is way too long. I put that at 6 months. I'm not saying that's healthy, but that's what would kind of be expected. And so you might and again, you wouldn't be able to diagnose someone based on that. It needs to at least be a year. But we're just talking about the differences in culture as to what is expected, how long are you allowed to grieve or expected to grieve as a result of how you grew up. Okay. All right. So we do need to talk about ACEs. All right, we're doing okay here. We're going to get through this. Okay, so along with trauma, we do need to talk about ACEs. And so this is kind of getting into how trauma is experienced and how even what could be considered like low-level stressors or trauma can combine to result in adverse outcomes in kids. So adverse childhood experiences. Okay. This is an acronym, again, for adverse childhood experiences. It originated in 95. Centers for CDC and Kaiser Permanente conducted a study. And this is an extraordinarily long study that's been done. But in the study, ACEs referred to 3 specific kinds of adversity kids faced at home, or various forms of physical and emotional abuse, neglect, and dysfunction in the household. And what they found, and again, thousands of pieces of data have been collected. So this is very, very strong. The evidence is very strong in regard to this. The key findings of these studies using the original ACEs, and we'll talk about those. ACEs are quite common, okay? Most of us probably have an ACE, an adverse childhood experience. More than 2/3 of the population report experiencing at least one, and nearly a quarter have experienced 3 or more. And what they've also found, there's a powerful, persistent relationship between the more ACEs you experience, the greater the chance of poor life outcomes. So the more stressors or traumas that one experiences early in life increases the risk of poor life outcomes. We'll talk about some of those, and they might include heart disease, diabetes, obesity, depression, substance abuse, smoking, poor academic achievement, time out of work, and early death. So it shows the overall cumulative impact of these stresses. Okay, so I'm just going to run through these. If you would like, please consider trying this out to look at how many ACEs do I have. Maybe your kids, maybe your siblings, it just kind of gives you an idea of like, oh, okay, that makes sense. Okay, so I'm going to answer this. Okay, let's see. Maybe I'm going to answer it. Okay, we'll see here. Awesome. Okay, so these are all prior to your 18th birthday, and you can answer yes or no, and then we'll score it at the end. So prior to your 18th birthday, yes or no, did a parent or other adult in the household, often or very often, swear at you, insult you, put you down, or humiliate you? Or act in a way that made you afraid that you might actually be hurt? If that's a yes, you get 1 point. If it's a no, you get 0. Same thing with all of these. If you say yes to any of these, you get 1. If you say no, you get 0. Did a parent or other adult in the household often or very often push, grab, slap, or throw something at you? Did they hit you so hard that you had marks or you were injured? Did an adult or person at least 5 years or older ever touch or fondle you, or have you touch their body in a sexual way, or attempt or actually have oral, anal, or vaginal intercourse with you? Did you often or very often feel that nobody in your family loved you or thought you were important or special? Or your family didn't look out for each other, feel close to each other, support each other? The next one. Did you often or very often feel that you didn't have enough to eat, had to wear dirty clothes, and had no one to protect you? Or your parents were too drunk or high to take care of you, or or take you to the doctor if you needed it? The next one is very simple. Were your parents ever separated or divorced? The next was your mother or stepmother. And I know this could shift because, again, we know that both male and female, men or women, can be victims of domestic violence, This is just the original ACE from 95. So, was your mother or stepmother often or very often pushed, grabbed, slapped, or had something thrown at her, or sometimes often or very often kicked, bitten, hit with a fist, or hit with something hard? Or was she ever repeatedly hit over at least a few minutes or threatened with a gun or a knife? The next one, did you live with anyone who was a problem drinker or alcoholic or somebody who used street drugs? Next one, was a household member depressed or mentally ill, or did somebody in your household attempt suicide? And then number 10, did a household member go to prison? Okay, so what you do is you add those up. You add those up, and then let me see here. Okay. Here's the thing, is that when it comes to your number, and again, this doesn't mean that this is exactly what's going to happen. It's just correlative. It's not causal. It's not causal. But it does help to explain why some people who have like adverse childhoods or were abused, like why they end up where they end up, or it's how amazing it is when somebody is able to get out and not end up like this. But in the original study, almost 2/3 of people reported at least one ACE. So about 2/3 of us are going to have at least one of those. And more than 1 in 5 had 3 or more ACEs, and 12% reported 4 or more. Now, here's the thing, is that as your ACE score increases, so does the risk of, again, disease, social and emotional problems. And if you have 4 or more ACEs, and again, so as it goes up, as the ACEs go up, so do your chances of these things. But once you hit 4 is kind of a big trigger point. The likelihood of like lung disease or, developing lung disease in your life, it goes up about 400%. Hepatitis, 240%. Depression, 460%. And here's the big one. There is an increase of 1,220% that you will attempt suicide once that ACE score hits 4. That's a number that I cannot completely conceptualize. And so I hope that this kind of shows you, as we're going through this, the importance of one's childhood and how fragile it is. Yes, kids are very resilient, but they're also very impressionable and they're like little sponges. Okay, so here's in regard to childhood experiences underlie later being sexually assaulted. If you have a 0, if you got 0 ACEs, you got a 5% chance, like the general population. 1, 10% chance. You got 2 ACEs, about 60% chance. 3, right around 18%. And again, 4 or more, we're all the way up to about 1 out of 3 people with 4 or more ACEs will experience a sexual assault. Alcoholism, 0, like with the general population, right around 3%. 1 jumps up to about 6. There's a big jump here between 1 and 2. You're up to 10% chance of developing alcoholism if you have at least 2. 3, that's about the same as 2, but 4 or more, we're jumping up to about 16%. 16% of people who have 4 or more ACEs could be diagnosed later with alcoholism. Now, again, I hope that you look into this a little bit. But while the ACE study was being done, there was also research on kids' brains done as well. And it found that toxic stress damages the structure and function of a child's developing brain. Again, childhood is it's a fragile time and a sensitive time for the development of the brain. It's when most of the brain is being developed. And when children are overloaded with stress hormones, something like, cortisol, adrenaline, they're going to be in flight, fight, or freeze mode. They can't learn in school. If you feel like you are getting chased by a bear at all times, you can't focus to learn. You can't focus to learn. Kids can't either. They often have difficulty trusting adults or developing healthy relationships with peers, so they might become loners. To relieve their anxiety, depression, guilt, shame, or inability to focus, they may turn to biochemical solutions, smoking, alcohol, weed, meth, or activities in which they can escape their problems. Again, it just increases the chances of these things happening because there's probably other things going on in the home and that might result in less supervision and things like that. High-risk sports, proliferation of sex partners, and work or overachievement. So with that, I mean, you might have a kid that, again, maybe doesn't do any homework or is maybe a straight A student. You might have a kid that, has nothing to do with any sort of activities, or they're the star on the football team. Also, this toxic stress, it can be passed down from generation to generation. This is the generational trauma. And again, we've talked about epigenetics. We did this 2 weeks ago now. We are born with genes that can be turned on and off, as we've discussed, and depending upon what's happening in the environment. If a kid grows up with too much stress, those response genes are probably going to be activated. So they're easily triggered by stressful situations that don't affect those who don't grow up with toxic stress. Again, if you're turning those on at an early age, they're going to be very sensitive throughout life. Whereas those of us who didn't experience that, those were never turned on at those sensitive periods of time. And so we can handle those things. And also they can pass that response on to their kids. Now, here's the thing is that fortunately our brains in lives in general are somewhat plastic. Our brains, it's called neuroplasticity, and that our brains can change. And again, you can turn genes on and off. And resilience research does show that the appropriate integration of resilience factors. So again, we've talked about these risk factors. I mean, all those ACEs that we just went over, those are all risk factors for all of these things we talk about. But I just hope you know that's not a causal relationship, is correlational. There's also these things called protective factors. Those are going to be the opposite of risk factors. Those are the things that you hope outweigh the risk factors. That even though maybe things aren't good at home, maybe there's a really great teacher that's mentoring the kid, or maybe they're going to a church group, or maybe there's a rec league, or maybe they have a great friend group, or maybe the next door neighbors, help and take care of them. But there's something that's protective. And again, like being able to ask somebody for help, developing trusting relationships with others and adults, being around people that are going to help you form a positive attitude, listening to feelings. All of these things can improve lives, even if those risk factors are in place. If there are enough protective factors, these negative outcomes are reduced significantly. And that's what's important, is making sure these kids are exposed to these protective factors. Okay. So just a couple more things here. Yep, we're right at the end. So when it comes to these trauma and stress-related disorders, there's 4 interventions, like CBT. We've talked about this. This is going to encompass both cognitive and behavioral aspects, cognitive processing therapy, and prolonged exposure. Those are all very commonly used within PTSD or stress-related disorders. There's a big one, though, that we're going to talk about here. So cognitive behavioral therapy, again, we talked about focusing on relationships among thoughts, feelings, and behaviors. We're going to look at current problems and symptoms and focusing on like, how can we change those? If we can change one aspect of this, it can improve functioning in other domains. So if we alter a person's unhelpful thinking, that can lead to healthier behaviors and improve emotional regulation as well. Again, we're looking at 12 to 16 sessions. Sometimes that'll be enough, sometimes it won't. Cognitive processing therapy. This is a type of CBT. It's going to help patients learn how to, change their beliefs and challenge those that are not helpful. It's usually delivered over 12 sessions. It basically helps you learn to challenge and modify unhelpful beliefs related to trauma. Again, like considering like those overly negative perspectives of themselves that like, I'm not worthwhile. That would be one that they would work on, modify that and challenge that's not true. In doing so, the client can create a new understanding and conceptualization of the event as well as their current life. There's also cognitive therapy, and this is going to modify the pessimistic evaluation and thoughts or the memories of the trauma. And so the goal is to interrupt all of the disturbing thought patterns that are interfering with somebody's life. It's usually delivered in weekly sessions over 3 months. Then there's prolonged exposure. This one's kind of tough, but they do it. Again, this is when we modify the pessimistic evaluations and memories with the goal of interrupting the disturbing behavior or thought patterns that have been interfering in their life. It's usually delivered in weekly sessions over 3 months. It's provided over a period of about 3 months with weekly individual sessions. 60 to 120-minute sessions are needed for the individual to engage in exposure and sufficiently process the experience little bit by little bit. Again, it's prolonged exposure. It's not flooding. So you're just being exposed to a little bit at a time. Here's what has been found to be very effective with PTSD. And I think this might work, actually. Let's see here. I think it's going to work. So, okay, now we've got an ad. I'll skip it. But
addiction is so.
Okay, we get it. Okay. So this is EMDR, eye movement desensitization and reprocessing therapy. And what happens is that this is literally what happens. There's usually a wand or something that's moving back and forth, and the therapist is going to ask you to just follow it back and forth, back and forth. And what's happening here is that it's activating both sides of the brain. And the therapist will ask you to focus on the trauma memory while again moving your eyes back and forth, back and forth. And what we found, it's associated with a reduction in the vividness and emotion associated with trauma. Now, exactly how this works, not quite sure, but it has been to be found. It was initially found to be very efficacious with Vietnam War vets. And it's been used across the board for a variety of disorders now. It's usually involved as individual therapy, 1 to 2 times per week, 6 to 12 sessions. It doesn't include exposure to distressing memories necessarily. All you have to do is focus on, the event to a certain degree. And there's usually not homework. Literally, this is what you do. You talk about certain aspects of it possibly. And again, you just focus back and forth, back and forth. And that aids in the processing of the event. And again, it's been found to be highly efficacious. So with that being said, there are a couple of medications as well, along with therapy that can be helpful. We have sertraline, paroxetine, like Prozac, Effexor. So basically your antidepressants that can work on some of the anxiety as well. But the only SSRI, Zoloft and Paxil are those that are FDA approved for treating PTSD. The SSRIs, the selective serotonin reuptake inhibitors, which we'll talk about more in depth in the mood disorder chapter, they are usually the first class of medications used in PTSD. There are exceptions that might occur for patients based upon their histories, side effects, response, comorbidities, or personal preferences. Even if we're talking about maybe somebody's having excessive nightmares as a symptom, they might be prescribed Prozosyn, which is a medication specifically to treat nightmares. So it truly just depends upon their symptoms as to what direction a clinician wants to take. Okay, I will not keep you any longer. I appreciate you watching this lecture. And if you have any questions or concerns, please let me know. And I hope you all have a great rest of the day, evening, whatever you're experiencing. Thanks.